So, who here would consider themselves pain-free? They have no pain. Nobody?
Good crowd.
So everybody has pain. Does that seem kind of common? Like when you talk to your...
Well, one arm is pain-free.
One arm is pain-free. Okay. You got an optimist back there. The glass is half full. That's what I like to see. Okay. So what we find commonly is, especially as you get older, and Dakota is super young. I'm kind of in the middle. I've got some aches and pains now, but as you kind of get older, then it's kind of rare to find someone that doesn't have any pain. So that's unfortunate, right? No one wants to have pain. And the biggest thing is that pain stops you from doing the things that you want to do. So you signed up today to come to a shoulder workshop. So our goal, and a big part of what we want to do is community education. My name is Travis Robbins. I'm the owner of Robbins Rehabilitation West. In a week, we'll have been open for 19 years. I can't believe I say that. Dakota, what were you doing 19 years ago?
You don't want to know.
Okay, got it. I think it was in grade school. So, what we really like to do in physical therapy, anybody had physical therapy? Raise your hand as long as it's not bothering your shoulder. Okay, so you guys kind of know what physical therapy looks like. What we like to say in physical therapy is we're really big educators. We're helping you make a decision, the next best step to take when you have some kind of discomfort, especially pain with movement. We feel, we're kind of biased, but if you have pain with movement and you didn't cut off your arm, physical therapy is probably one of the best places that you can go. It's conservative care. Let me know what conservative care is. It's like in the absence of injections, medications, and surgery, okay? So that's a little bit more invasive. Physical therapy is less invasive. Doesn't mean you never use that stuff, right? At some point, I'm going to need a really good surgeon, I bet you, okay? But we want to try to fix problems before it gets to that point. And we also send people out for different medications and injections. That happens, at some frequency in our practice. But what we want to try to do is handle things conservatively. So one of the things that we like to do are these workshops and education. So you're going to have this sheet right here. So we're going to work off of this. We have tried to trim this down into the most important information that you can have when it comes to figuring out what's going on with your shoulder pain. That's the number one thing you got to do. You got to figure out the cause of your shoulder pain. If you can find the cause, then usually the solution follows right after that. So, understanding the top 3 causes of shoulder pain. So Dakota's going to go over these. When someone comes in and they have shoulder pain, I'm going to go ahead and guess that most of you are having shoulder pain kind of in the front of your shoulder and gets worse when you reach for something overhead. Is that true? Just kind of raise your hand if that's true.
You can. It hurts when I raise my hand.
Can't even do it. Can't raise his hand. Right? There you go. This is the heckler. Okay. So that's pretty common. Dakota, if someone comes in and says, yeah, I got pain right here, it gets worse when I raise overhead, what are some of the structures that can be causing that pain?
Yep, so we're going to work right down the list there. The most common thing that I'll hear from someone when they walk in the clinic and they say they have shoulder pain is they're like, oh, I know someone that had their rotator cuff torn and they had to get surgery right away. Like, do I need surgery? That's the number one thing that I hear every time someone walks in the clinic. That's just the most common thing that people will hear. Because if you go and you went to maybe you saw an orthopedic doctor before you came into physical therapy, most likely they're going to check your rotator cuff. That's the number one thing. Because, to be fair, if you're above the age of 40, there's what,
hold on, quiz him.
All right. What does everybody think the percent chance is that if you went and got an MRI today and you're over the age of 40, that you'd have a rotator cuff tear?
The thing,
of any degree, too. It doesn't have to be a big tear. It doesn't have to be like the thing is not attached whatsoever and hanging by a thread. It could be as small as a slight tear, a partial tear. Okay, it doesn't have to be anything significant where you might still have full range of motion. You just have pain.
And I'll take that. We have to exclude a lot of you people because in this study, the patients had no shoulder pain. Okay, so they, no shoulder pain. When they get MRI over the age of 40, what percentage of those people had a rotator cuff tear?
50%.
50%, 60%. And we want to go higher?
I'll go on 60.
Yeah, right around 60%. Okay, asymptomatic, meaning no symptoms. Okay, so it's a really common thing to find. That's a diagnostic finding, and it can be found in people that don't have any pain at all. So if you have shoulder pain and you go to your doctor and you get an MRI and it shows a rotator cuff tear, is it guaranteed that that's what's causing the problem? No. Could they do surgery on that if they saw that? I'm a surgeon. I see a tear. I could do surgery on that, right? Okay, so that's why we want to try to rule out this kind of stuff. So super common problem and can be something that also causes a lot of symptoms as well. So I don't want you to think that those don't cause symptoms. They do cause symptoms.
Yeah, but I feel like the key takeaway point from that is really the fact that if you have pain, yes, it can be from that, because that's maybe what people will say the most common, but it's also very common to have people without pain with that. So don't, if you go to a surgeon, that's going to be their kind of next thing that they want to do is just do surgery. That's their job versus Travis and I. It's a little bit above our pay grade. We're going to be doing that conservative care that we talked about before. So that's the number one thing. Now with a rotator cuff tear, other than having pain with reaching overhead or maybe reaching out in front of you or maybe your arm behind your back in and around the front of the shoulder, kind of back of the shoulder area, I typically will see patients, especially if they have a significant tear that requires surgery, that's going to be they can't lift their arm up overhead like at all. Again, Travis said first and foremost, if you can reach up overhead, that's to me likely not a candidate for surgery. I mean, it doesn't mean it's not absolutely, but for us, that's something that we can fix a lot easier. You have a lot more range of motion, okay? That's going to be the biggest thing. Now, does anybody know what the rotator cuff does? Shake the head.
What's it do?
I cheat, I'm a registered nurse.
Okay. All right,
Skip.
so we'll
Pass.
I say, anybody else want to take a stab at it? Anybody? All right, so the rotator cuff stabilizes the shoulder joint. So it basically keeps it centered. So the way that the shoulder looks, it's basically a golf ball that sits on a tee. So if anybody's seen a golf ball that sits on a tee, it's a lot more golf ball than there is tee. Okay? So it's basically keep that joint together and not dislocate or kind of separate. The rotator cuff needs to be really, really strong. Okay? If it's not strong, that can give us shoulder pain, especially when we're reaching up overhead with or without weight. Obviously, with weight, it's going to be more difficult because it's going to challenge the rotator cuff more. But that's really the goal of the rotator cuff, is to stabilize. Those are muscles, and typically they say there's 4. I think we think there's 5. People will argue about how many muscles there are in the rotator cuff, but either way, the goal of the rotator cuff is to stabilize the shoulder joint, especially when we're lifting, carrying, reaching, even getting up off the floor. You need your rotator cuff to kind of help push up out of a chair off the floor, simple things like that, right? The next one on here is the labrum. So I'm going to go back to the analogy that I just used with the golf ball and the tee. So if you have golf ball sitting on the tee, okay, and there's, again, not a lot of room for that golf ball to sit on the tee, other than the rotator cuff to give the joint stability through muscular contraction, we actually use another way to stabilize the shoulder, and that's through the labrum. So has anybody heard of the labrum? I know I asked about the rotator cuff, so we had 2 for 2. I think I'm going to believe him at this point because he's probably going to deny to.
Actually, I have a slap.
You have a slap tear? Okay, so that's going to be one of the most common tears that we'll hear in physical therapy when someone tears their labrum. So the labrum, has anybody ever seen, this analogy we like to use, anybody ever seen like a suction cup that you stick on the wall and you can like hook, put like a towel on it? Okay, so that's essentially what the labrum is. The labrum is that suction cup, okay? And if you ever try to stick a suction cup on the wall that has a small tear on the edge of it, it doesn't do its job very well, right? So that's exactly the point of the labrum. So the labrum sits on top of the scapula. So we actually have I'm going to pull our skeleton out here so kind of can help everybody imagine and see this. So here we have the scapula, the shoulder blade, okay? And here we're using that analogy where we have the ball sitting on the tee, okay? Now the labrum sits right here on the end of the scapula, okay? It's called the glenoid fossa. So if there's a small tear there, then what's going to happen is it's going to allow that ball to basically slide around a little bit too much. So it's losing stability. So the only way for us, like the labrum also doesn't have a great blood supply, so you can't strengthen the labrum. It's not a muscle. It's actually like a piece of connective tissue, kind of like the meniscus. Anybody in here ever have a knee issue where they tore their meniscus or say that they've had a torn meniscus? So it sort of works like that, okay, a little different, but pretty same tissue, okay? And when you have a labral issue, a lot of people will say they can have pinching, still with pain, reaching up overhead, things like that, but a lot of times people will say, my shoulder just doesn't feel stable. Okay, they still have pain. They might be pretty strong. We can strength test them and test their strength, and they're actually pretty strong. But what's happening there is they're losing stability, especially lifting overhead with weights, because that suction cup just isn't keeping that joint together as it should. Okay. Now, last one. For anybody that watched Travis's video that he shot with me, does anybody, before we keep going, have the answer to what they thought Travis was dealing with?
So
saw that video.
Dakota did some testing on me. So this orthopedic test that we're going to go over that physical therapists can do to try to decide if the labrum's involved, if the rotator cuff's involved, or if something else is involved. So all my labrum, I have pain in front of my shoulder. It gets worse when I go out to the side and when I go up here. And my labrum tests are negative and my rotator cuff tests are negative. So what's another thing that can be causing pain in the shoulder when you move it?
Arthritis.
Arthritis, so that's kind of joint related, which would be more like meniscus, but yeah, it can be arthritis for sure.
The nerve.
Yeah, you got it. Nerve.
Yep.
Okay. So Dakota, explain that.
Yeah, so I think going back to what I said earlier, where people will hear at least the rotator cuff, that's the most common thing that people will hear of, okay, or think like, oh, it's got to be a rotator cuff issue because they know someone down the street or someone in their family. Next thing will be the labrum, so it's something else. If someone knows one, if not both, those are going to be the first two. But then the nerves. So we have nerves that come out of our neck and out of every spot in our spine, but the ones out of our neck supply the sensation and pain and the way for our muscles to contract down our entire arm. Now, it doesn't mean that you have a neck issue if there's a nerve issue, because a nerve can be trapped anywhere. One of the most common places is our spine or our neck or our low back, okay? But it can also be trapped by muscles. If certain muscles are tight or certain joints don't move properly, that can be leading to that. And what also can be happening is just the way that a muscle can be pinched in the shoulder, depending on our posture, depending on our strength or just overall mobility, that nerve can also be getting irritated. Now, with a rotator cuff tear and with a labral tear, rarely do people have pain that radiates. So meaning that person usually has a lot more of their pain just localized up in the shoulder. It's not really going too far down the arm. But with nerve pain, that can go down the entire arm. So if anybody's heard of sciatica, that's similar to kind of what I'm talking about. That's just in the leg, okay? So with a nerve pain, still can be localized, still can be getting pinched up in the shoulder. But one thing, I know I'm kind of jumping ahead a little bit here, but sometimes we'll always ask patients when they come in, do you have any pain that goes down your arm? And sometimes that can be an indicator of a nerve issue because the rotator cuff just doesn't refer down the arm. That's going to be, again, more of a nerve issue. Now, we have a few nerves that go down the arm, so there are a few special tests that we have at our disposal to kind of differentiate what's going on there. But if someone says they complain of numbness or tingling, that's not a muscle, that's not your labrum, that's a nerve. And a lot of people will come in with shoulder pain and then also hand numbness or tingling, like, oh, I think I have carpal tunnel. And Travis and I were looking at this thing, and we're like, that might be the same thing, just to gotta find out what's the cause of all this. So that's really what we're seeing when we have a nerve issue. Now, nerve is just like a muscle. It needs to be able to stretch and move. So that's really how we address more of that issue, is getting it to just move better. Now, it can be that we have to stretch it out and do some techniques for that. But people can have burning pain just the same way as the rotator cuff, okay? And they can have it in the same position, but then also sometimes people say, yeah, this pain that goes down my arm too with it. That's not going to be rotator cuff, that's going to be nerve pain. So those are the three most common things that we see that when they walk in the clinic. Now, does anybody have any questions about any of those? I know there's a little bit of overlap, but I want to make sure it's pretty clear some of the differences at least. Yeah.
I've heard of a frozen shoulder. Is that any one of these three things? Or is it something entirely different, or doesn't it even exist?
It definitely exists.
Absolutely.
Unfortunately. I'll tell you, there's a couple things you don't want. A frozen shoulder is one of them because they're awful. Do you have a frozen shoulder? You know someone that has a frozen shoulder?
I knew a friend that did.
Okay. All right. So Dakota's going to explain kind of what that is.
Yep. So with a frozen shoulder, if we kind of look back at the joint, what the classic frozen shoulder is we talked about the labrum, we talked about the muscles, but what we didn't talk about is the joint capsule. So there's a capsule that surrounds every joint in our body, and basically that just gives it some protection as well as some of the nutrients. So our joints, to prevent arthritis, we have synovial fluid. It's essentially WD-40. Now, if there's a lot of reasons that can cause frozen shoulder. So one of them is like if someone has a fall and they might break their arm, unfortunately, that can eventually lead to a frozen shoulder if they don't move their arm for quite a long period of time. Now, it's again rare, but it does happen, and there can be multiple reasons. It can be traumatic. Some of them are even atraumatic. There's people that come in and say, I don't know what that guy did. My shoulder's like stuck like this. But one thing I will say that I've seen a lot in the clinic is some people say, they come in and say, yeah, this frozen shoulder, and it sounds like frozen shoulder, it looks like frozen shoulder. In terms of like the range of motion is usually pretty severely lost. And then when I check them for nerve mobility, that's the one thing that is really, really positive, and this person responds very, very well. I've had a couple of people, I have one person right now actually who came in complaining about a frozen shoulder. She was going to physical therapy somewhere else for a few months and really wasn't getting better, got a little bit better, and she came in and I worked on, I didn't really even stretch out her shoulder a lot. I worked on her neck and the nerve mobility, and her shoulder got better in like 2 months. It got 50% better. So it does happen. Like there's true frozen shoulder, but I think what will happen is people will go get an MRI and it looks like a frozen shoulder and they might have some positive diagnostic findings, but their assessment totally is just the muscles and the bones, and it has nothing to do with like the nerve mobility. So it's definitely a real diagnosis. Like Travis said, you don't want to see it happen because it's usually pretty limiting. Those people will not be able to raise their arm much above shoulder level with a frozen shoulder. But
yeah, for those patients, a lot of the second, third opinion stuff we see is nerve related. because it's something that's really commonly missed, especially in physical therapy. So and what Dakota was saying is frozen shoulder and nerve limitation, their mobility looks very similar, because if you have a really entrapped nerve and it's angry and you go to move, it gets really, really angry. So does anybody know what a common treatment is for a frozen shoulder? Surgical treatment. It's not really a surgery, but they knock you out to do it. So they'll do a manipulation under anesthesia. So they'll knock you out and they'll get on the table. If you've never seen this, don't watch it because it's hard to watch. They'll knock you out and they will force you into full range of motion. Okay? So now if the problem really is adhesive capsulitis and a capsule problem, it can be helpful. But a lot of the times, it's just a nerve limitation. So what do you think is going to happen if a nerve is so angry that you can barely move it, and then I knock you out, and then I force it to go? Nothing good. Okay? So it's really important that if you find someone that does a lot of treatment of nerve mobility, and that's typically a weird thing. Like, do you guys know how nerves move? Like, you probably have a concept of how muscles move and how joints move, and there's a lot of biomechanics behind it, but nerve mobility is weird. It just doesn't, if you don't know what you're doing for in terms of testing and treatment, then you're going to miss that kind of stuff. So what we have are tests. So two things that you need to do to try to find the cause of the pain. We talked about that, right? The most important thing is we've got to find what's causing this pain. Is it a rotator cuff? Is it a nerve mobility issue? Is it a labrum issue? Because the treatment for that is different. Some of it does look similar, but some of it is very different. So the first thing is the history of the injury. So that tells us a lot. So I've been doing this for 20 years. Dakota's been doing this for a little bit less than that. But for the most part, after I'm done talking to you, before I even get my hands on it, I have a pretty good idea of what's going on based on what the story of what you've told. So that's really important. So how much, have you guys been to the doctor recently? How much time do you get with the doctor?
15 minutes.
That's a lot. Yeah.
I was
Average.
gonna ask her who your doctor is.
Yeah, right. I need a doctor like that. Average is about 8 minutes. That's about. And man, it is tough. I don't know. General practitioner, there ain't a tougher job than that. Someone's in the weight room's got a cold. Someone's got like a sore on their ankle. Someone has some back pain. Someone's got some weird rash. Like, how do you know all that stuff? And you got to figure it out in 8 minutes. Really, really hard. So the good docs send it out to people. This is all we do. Like, we spend an hour with you when you're on the table, and we have the time to figure this out. Doctors don't have the time to figure that out. So it's really important that you know the history. The other thing you need to do really good at is orthopedic tests. So is anybody having shoulder pain right now that would be willing to come up to have us do a couple tests on you? Yeah? All right, come on up. All right, so we'll go through this really quick.
4 days, I can use something.
So quick, tell us your story. We're going to do the 8-minute version.
Okay. Quickly, I'm a nurse by day, but I'm a musician in the evening. And I had a really tough gig that I was working a lot for. And I have a 96-pound bass cabinets. And after working with my arm like this for like 4 hours a night, when I got done with the gig, the next morning I couldn't move my shoulder at all. I mean, I could go almost up to my neck with this. That's it.
How long did this happen?
What's that?
How long ago did this happen?
May, June.
May or June last year?
Yeah, and
Okay.
then in November, I got x-rays and an MRI. And do you want to know what my diagnosis was, or do you want to do the test?
Let me see, what did the diagnostic testing say?
The MRI showed a slap tear in my right shoulder, and then I also had one on my neck, which I knew because I have a lot of history of neck problems. I've got a C7 or C5 bulging, which is just the disc, which is the cushion between your vertebra, and the nerve is right here, and the disc is just barely touching the nerve. And all you need is the weight of a penny for that nerve to just shut down and say, I'm not going to work anymore. So in certain neck positions, that'll touch it, and my arm just goes dead. It doesn't want to work anymore.
Okay. You have a lot of pain in your arm, or not really?
Not right now. I just did my stretches.
Yeah.
But I get some isolated pain here, some isolated pain here, but then I get some numbness and some mostly numbness and down my arm.
Okay, so Dakota talked about numbness down the arm. What does that look like? Nerve? You guys are like physical therapists. Like one more class, you could be a physical therapist. All right, and now we got to try to find out, well, so now we have some diagnostic testing, right? But we know that diagnostic testing isn't always the answer. It's good information. I typically don't want to know what's going on. I typically don't want my patients to get diagnostic testing because guess what? I've never gotten an MRI back from a doctor on a patient and it said, looks good at the bottom. It never said that. There's always going to be something there. So when you have significant structural issues in there, sometimes the patient thinks, wow, like nothing's going to fix this but surgery, right? I've got this disc that's pushing on a nerve. Man, unless I do surgery, like, I can't fix that. We don't even know how much that's involved. Like that, it sounds like it is, just because based on symptoms. But it might not be. It might be some kind of other entrapment of that nerve in here. It might be that the inflammation from the slap lesion is putting pressure on it. It could be a lot of different things. It doesn't mean that that is the problem. And the biggest example I give you is for knee replacements. So we have tons of patients, not tons of patients. We have patients that come in, they have really bad knee pain. What happens when you have really bad knee pain? You go to the doctor and they do what? They take an x-ray. What are they looking at? The space in between the femur and the tibia. And they'll look at it on both sides. And they'll say, okay, your meniscus is not there anymore. There's too much, there's like bone on bone. You ever hear that?
Yeah.
Well, what procedure are you gonna have after the doctor sees that? Knee replacement, right? So we have patients that come in, terrible knee pain. They have the knee replacement, they have a brand new knee. We fix the knee, like normal range of motion, strength, everything's fine, but the patient says, Travis, I still have this knee pain. It's the same exact knee pain I had before the surgery. It's because that's not where it was coming from. It's coming from the back. Okay? So common here, like we could do surgery to fix this kind of stuff. That main symptom of nerve irritation, if that's still there after the surgery, then that's not really what was causing the problem. So let's do a couple orthopedic tests. We'll just show you guys really quick. We don't advise you to do this at home. I'll tell you a quick story. I had a friend of mine who's a PT, went into his orthopedic surgeon as a friend of his and did some of these tests, and he had a partially torn bicep tendon, and then the surgeon completely tore it. That's not what's going to happen here, right, Dakota? Okay, good. All right, so let's do a couple orthopedic tests. So we're going to do some tests. Test rotator cuff, and we're going to test labrum. So go ahead.
Your malpractice is paid up, right?
It's, oh my God, double, triple.
Okay, good.
Yeah.
All right, first one I want to do is just have your arm up like this, thumb down.
And you guys can actually do this. If
So
you have pain in front of your
up to the
shoulder,
side. Now what I want you to do
this
is I want you to
is
hold it
called
there.
an empty
Don't
can
push it
test.
down.
So you just kind of put your thumb down. If getting this position is
Pain with
painful,
that?
don't go any further with it.
Feel it,
Okay, does anybody have
Feel it
pain
right
there?
there?
Okay,
Okay, so now
so
let's relax
really
the arm.
lightly, what you're going to do is just put a little pressure on that. When you put pressure, so try to keep your arm there, but you're going to push down on it. Does that pain get worse? Anybody have pain
How's
that
the
gets
hand
worse
doing
in that
that?
position? A little bit more in there?
It
Yep.
does get worse.
So-
I just know it.
That's a supraspinatus test. So it's specific to this one tendon that is the most commonly torn tendon in the rotator cuff, and irritated, by the way. So don't always think everything's torn. Sometimes it can be really irritated, and that causes
Yeah.
pain. When you put pressure on it, that muscle has to activate, and it doesn't like it. It gets angry. Okay, so that means there's some kind of inflammation or maybe a partial tear.
Like $1,000,000.
All right, did you get anything?
So positive with that. So
Okay.
positive for that
Positive
one.
test.
All right, now we're gonna flip that right over like this. So same test. Yep, and this is a biceps test. It's called a speeds test. Me and Dakota are still trying to find something we can name ourselves after. All these tests are named after somebody that came up with it. So from here, you're gonna do the same thing. Okay, so first off, if this position is very painful for you, then don't push down on it, okay? But if you can tolerate it, if you push down on it, okay, if that reproduces pain in your shoulder, does that cause increase in pain, anybody in the shoulder? A little bit? Okay, so we're putting stress on the bicep tendon. The bicep tendon attaches into what, Dakota?
The labrum.
Right, okay, so what
Which
happens
is
here?
interesting because I tested him and it was actually negative. So I would have expected that before if he would have had positive findings for that to be painful. So that one actually felt okay, which is a little bit shocking, again, given that he had the history of the MRI having some positive findings.
Yep. All right, so let's do, if you guys can do this one, again, you can do this one on your own too. So it's kind of a similar test, but you're gonna cross over. Again, if this is painful, don't push it. Okay? So from here, you can tell he's kind of hesitating to get in there, right? Now put your thumb down. Okay, now really lightly, push down on that. Okay, does that make the pain in your shoulder a little bit? Okay, now immediately from there, flip your thumb up and then push down. Now this one's a little confusing. If you push down with your thumb up, does the pain get better than it was when your thumb was down? Okay? This is a positive test for a labrum issue. Okay? So if you have pain when you push down, it causes me a little bit of pain, right? Some weakness there. And then I turn it up and then push down. If it's like, yeah, that doesn't feel very bad, that can indicate positive tests for labrum. Again, these tests are not perfect. Okay? The perfect test is we open them up right now and look in there and see what's going on. Okay? That's very invasive. That's why MRIs are great.
I gotta be home in an hour.
I know, so we're not going to do that. I didn't even wash my hands that much today. So we're not going to do that. Okay, MRIs are really great because they are, as compared to exploratory surgery, minimally invasive. They do give us information there. But any surgeon will tell you, if you've anybody ever observed a surgery? Okay, if you ever observe a shoulder surgery, we'll put the films up on the board and we'll say, yeah, I think this is what's happening, but I won't know until I get in there. Okay, that's why they always, if you ever had surgery, it's like, hey, I'm going to plan this for about 45 minutes. Now, once I get in there, you might be there for a couple hours. I don't know what's going on in there until I actually get in there. Again, MRI is a really cool tool, but it's not perfect. Perfect is like open up and look at this. So that's kind of what we're trying to do. We're trying to get in there with some tests that are non-invasive. We didn't open you up, right? And gives us information about what's going on inside of the shoulder. So those are the two most important things that you can do, is to find a good history and then go through some orthopedic tests that are not perfect, but give us pretty good information about what's going on. Okay, so what do you think? This is weird, right?
Yeah.
Because he's got a slap lesion. On MRI, we do the tests that should be positive for slap lesions, not that irritating. So, does he have a slap tear in there? One, could be, or maybe the film is not great. Okay, so it could be. And if he has a tear, maybe it's not causing that much of a problem. Right? So we have to do some other things to try to figure that out. But that's pretty cool because he has diagnostic testing that says he has a specific issue, and when we test it, it's really not that irritating. Make sense? Any questions about that? Awesome. Thanks for coming up. Appreciate it. All right. So now we're going to show you something that no matter what is causing your shoulder pain should help you out. Does anybody know what the thoracic spine is? Okay. He's always raising her hand. There you go. Oh yeah, she just had therapy for her thoracic spine. So your thoracic spine is the stuff that is stuck in between your cervical spine, which is your neck, and your lumbar spine, which is the low back. There's 12 segments right in the middle. Does anybody know what good posture is? They may have really good posture?
No.
Everybody says they have terrible posture, but then they kind of don't know what good posture is. But really, the easiest thing to say is, what does your grandmother say? Sit up straight, right? That's what your grandma's always doing. Okay, so I'm going to show you a really simple postural exercise. This is going to seem like, how the heck is like improving my posture going to take away shoulder symptoms? If you're in terrible posture, you're just a shoulder problem waiting to happen. So I'll show you how this works, right? So you guys said you all have bad posture, so just sit in really like crappy posture. So just kind of come forward like this, okay? Anybody spend like time doing this during the day, maybe? Okay. So now keep in this posture, this forward posture, and I want you to take your good shoulder. So if you've got one shoulder that's bothering you, don't do it. My shoulder's bothering me here, so I'm gonna do this one. And just lift your arm up as far as you can go. Like absolutely as far as you can go. Okay, and then kind of get an idea of where this is. Okay, now all I want you to do is bring your arm down, pretend like you had a 10-pound weight on your head, and push it up towards the ceiling. Okay? And now lift that arm up. Okay, did that motion improve at all? Okay. Do you think that if I'm down here and I go to reach for stuff up here, that I might cause some irritation of the structures in front of my shoulder? Okay? So if you can kind of clean up your posture, then it will take stress off of your rotator cuff. So we talked about rotator cuff tears, but a lot of times the rotator cuff is just irritated, right? And if I do this a lot in poor posture, and I'm just going in the front of my rotator cuff, it's going to get irritated. Right? So improving thoracic extension is really important. Does anybody know how to improve their thoracic extension? So flexion is here, like this is where we're bent over in bad posture. Extension is up here. Does anybody know how to improve that? Don't overthink it.
Squeeze the shoulders.
Squeeze your shoulders together, okay? And just get into more extension, okay? What's the easiest position to get into thoracic extension in? Anybody know? Okay, so it's laying down on your back, right? So if I just lay down on my back, naturally I'm gonna get into more thoracic extension, okay? But you guys are all sitting with chairs with backs on them, right? And they're probably coming up to about the middle of your thoracic spine, okay? So here's what I want you to do. If you can tolerate it, if you can put your hands to the back of your head, do that. If you can't, then just kind of cross them over here. So if you're having a lot of shoulder pain, then don't put them above your head. But yeah, here we go. So we got a little bit of both, right? Okay, so I want you to lean back on this chair, okay? And then you're gonna turn to the side, okay? Do you feel any pressure where that chair is pushing on your spine? Okay? If you're not feeling pressure, you can extend back a little bit further, right? And you can extend back and then rotate, and then you can also side bend. Okay, so use that as support. So extend back, rotate, and side bend. So we spend a lot of time, most people spend 8 hours or more sitting during the day. Okay? It is really hard to have good pressure or good posture when you're sitting. Gravity's pushing down on you. Everything is kind of getting you to spill forward. You don't have to spend 8 hours in extension to correct this. You just have to spend a little bit of time in extension to correct that. So just doing that exercise, getting into extension, just laying flat on the floor. If you come in for physical therapy, we're going to get you on a foam roller, and that will put extra pressure on your thoracic spine to get you into extension, and that will help out in terms of getting your shoulder in better position so you're not irritating it so much. Does that make sense? So if you're having shoulder pain, one of the most effective things you can do to stop that irritation is just to get into better posture, and that usually means getting into thoracic extension. Anybody have any questions about that? All right. So if you guys are interested, you came here on is it Monday? Is it a Monday?
Yep.
Okay. Yeah, I think I have 4 kids. I don't know what it is. If you came here on your Monday off to come hear us talk, probably something going on with your shoulder. So the next most logical step is to get it checked out. Okay? So anybody that comes to any of our workshops, we do a couple things for you. One, you've got that ultimate guide for shoulder pain. So that stuff really works. Like, look at that. There's exercises. There's actually programming in there that you can do that will help you out with that. If you're having pain with that, pain with any kind of motion is not okay. That's when you have to kind of take the next step. Really, the easiest thing you can do is come in for a free screen. So it's a 30-minute appointment with one of our PTs where we check things out for you. So we run you through all of these tests. It's absolutely free. Why do we do that for free? Because a lot of people have done a lot of different things to try to help their shoulder pain. So you've had this problem for a while, like since last summer. What have you done to try to get it better?
Well, of course, I tried the first thing, which is what I normally do for regular skeletal maintenance, and that's my chiropractor.
Okay, so with chiropractor, good.
I did the chiropractor, and it wasn't getting any better. And I'm like, well, if it was coming from my neck, what a lot of doctors said it was, they said it was all coming from your neck, a shot of steroids will cure it up like that. No,
Yeah.
it won't. But
Did you get an injection or no?
I did not.
Okay.
I got one quick injection because I know the doctor personally. He said, if you want, I can throw some steroids in there and see what happens. So he went to my shoulder, not my neck.
Okay.
He went to my shoulder. So I said, hit me up with it. Let's see what happens next.
Okay. Did it help?
No.
Didn't help? Okay.
Didn't do a darn thing. And then I went to chiropractic, and I'm good friends with a phenomenal acupuncturist in
Okay.
Lehigh Valley. And he wasn't having too much luck.
Okay.
And so I went to a surgeon, which was recommended by a friend to be a really good guy. And the guy took one look at my MRI and X-rays. He said, you don't need surgery.
Okay, good.
He said, go to PT. So next morning I called up St. Luke's, went to PT, said bye-bye. Next day I called Robbins and
Got it. So what you don't know is like we paid him a lot of money for that testimonial. So back to the point that I made. So why do we make it free? Because people have done a lot of different stuff. They typically paid some money, and it's like, come on, man, I'm going to try like one more thing to see if this works, and it's very frustrating. So I've taken that off the table. So that's not an excuse you can use. Okay? So you can come in and get a 30-minute appointment with one of our PTs, absolutely free, and we're just going to run you through these orthopedic tests, tell you what's going on based on our experience and our knowledge, and then give you options. So it can be physical therapy. For the most part, if you walked in and you didn't cut your arm off and you have shoulder pain, you're probably going to be appropriate for physical therapy. You at least want to fail that. You want to, there's a term in medicine where it's like you want to fail conservative care, which in its surface just doesn't sound very good, but it's the best way you can say it. You want to try to do all the things conservatively. Physical, not just physical therapy, chiropractic, acupuncture, massage therapy, anything we can do right up until surgery. Because after surgery, like everything changes and you cannot go back. Okay? A lot of times surgeries go great. We see the other end of it where surgeries don't go great, and we want to try to prevent that as much as possible. So if you guys want to come in for one of those free screens, then talk to Zoe. She can schedule you for that. Dakota has some this week. If we fill those up, then I'll come in and help out and do that. But I would encourage you to at least do that. Just get someone to take a look at it to try to find out what's going on. Because most of the time, 90% of the time, when people come in, you guys walked in here, and I saw you were moving your arms. So, well, I didn't see anybody who was like this. When I see this, I'm like, oh, that might be, again, above my pay grade, right? But we can help you figure that out, too. And it's not always physical therapy. Sometimes we refer out for other practitioners that we feel can help you out more than we can. Does that make sense? Mm-hmm. Anybody have any questions about anything? Okay, so we'll stick around if you guys have questions that you want to ask us. If you guys want to take advantage of that free screen, then go up and talk to Zoe, and she can get you scheduled in for that. Sound good? Thanks for coming, guys. Thank you. Ooh, applause.
Very educational. Thank you.